Dr. Nasser.
No he podido terminar la asamblea. Punto. ¿Todo bien sin la intervención? ¿Qué tal El-Ghandour?
يلا
5 4 3 2 1.
Good morning, good afternoon, good evening. It depends on where you are. My name is Nasser El-Ghandour. I'm president of the Egyptian Society of Neurological Surgeons, Secretary General of the Continental Association of African Neurosurgical Societies, and the second vice president at large of the World Federation of Neurosurgical Societies, the WFNS. Ladies and gentlemen, it gives me immense pleasure to welcome all of you in this educational symposium, webinar number 17, among the series of webinars organized by the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies. This webinar in particular is organized in collaboration with the Education and Training Committee of the World Federation of Neurosurgical Societies, the WFNS. I would like to express my sincere appreciation to all our distinguished speakers from different countries. I will go by the order by which they speak. Professor Richard Byrne, he is the director of the American Board of Neurological Surgeons. Professor Franco Servadier, he is the president of the World Federation of Neurosurgical Societies. Professor Miguel Arez, the chairman of the World Federation of Neurosurgical Societies Foundation. Professor Yusuf Bouzoba, consultant neurosurgeon from Morocco. Professor Isabel Germano, she's the chairman of the Education and Training Committee, WFNS. Professor Suad Bakhti, she is the president of the Algerian Society of Neurosurgery. And finally, Professor Francisco Meri, professor of neurosurgery, University of Chicago at Illinois. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. As second vice president at large of the World Federation of Neurosurgical Societies, I understand that one of the most important missions of our organization is to promote educational activity among all young neurosurgeons, especially in the developing countries. I'm particularly pleased and humbled by the active role played by the World Federation of Neurosurgical Societies in the process of training and education. It's my pleasure to announce opening of the symposium, and I will be honored to be the moderator of this session, together with Professor Mahmoud Qorashi, President of CANS, and Professor Isabel Germano. Before starting the webinar, I would like to invite Franco Servadier to give a welcome note as President of the World Federation of Neurosurgical Societies.
Dear Professor El-Ghandour, dear Isabel, co-organizers of this session, dear friends and dear colleagues, dear neurosurgeons from Egypt and from Africa. It's a difficult time for all of us. I am living in a country and in an area which was hit first in March in Europe by the COVID, and still we are dealing with the issue of the pandemic. It's a difficult time for all of us because we discovered that before becoming neurosurgeons, we are doctors, we are physicians, and we have to cure the disease that people has and that we need to cure. And we are deeply involved in a social cure of this pandemic. So how to keep education alive, we discovered that we have many systems, and the system of remote teaching as the one we have now, it's really fitting in our educational plan. And as we were saying before, many neurosurgeons from countries with limited facilities like Africa, East Asia, and so on, could participate actively to these webinar and meetings as before they could not find the resources to travel to the meetings, to pay for the registration in courses and so on. So in this terrible pandemic, we also discovered the possibility to spread out the education and the knowledge. And this is a very good effect. I heard before that the Egyptian Society has already organized 17 webinars. And this is like everyone all over the world. So I'm very happy to be here with you, and I'm happy to work with Professor El-Ghandour, Isabel, and all the friends for the success of this webinar. Thank you.
I think Professor El-Ghandour was muted, but we saw his lips moving, and I recognized that he mentioned my name.
I introduced Professor Isabel Germano, Chairman of Education and Training Committee, to say her welcome note.
Thank you, Professor El-Ghandour, Professor Servadei. It is really a pleasure to collaborate with you, Professor Qureshi. As you know, and as has already been said, the World Federation of Neurosurgical Societies Education Committee is a committee that really focuses on training and education around the world. And COVID has made it slightly different. However, we've been able to reach out to more people. And today is a great example. And we're really happy to do this in collaboration with CANS. And we know there are more that are coming up, hopefully. And this is giving us the opportunity to really be together, although it's virtual, but at least we can continue on our mission. It's important to remark that every single person in the education committee is volunteering to do this. And therefore, I would like to really give a big shout out to every person today here, every faculty that is dedicating their time and effort for education, and also all the other members of the committee that are not part of this seminar, but have been part of other seminars. I really appreciate your dedication, and thank you for sharing this passion in education with all of us.
Thank you, Isabel. Professor Mahmoud Qureshi, President of CANS, is going to say a welcome note.
Thank you very much, Nasser. It's indeed a pleasure and an honor to have such a distinguished panel. Professor Franco Servadei, President of the World Federation, Miguel Arraez, Chairman of the WFNS Foundation, Isabella, who we've just heard, Chairman of the Education Committee of the World Federation, Professor Bouzouba from Morocco, an old friend and colleague, will be participating. It's always a pleasure to see Suad Bakhti participate. And Francisco, thank you very much for joining in this excellent webinar. We, from the Continental Association of African Neurosurgical Societies, are absolutely delighted and honored to have such a galaxy of faculty to give us the talks that have been wonderfully outlined by Isabella, and working closely with Miguel Arraez and Professor El-Ghandour. So without taking too much of your time, thank you very much from the Continental, all the member societies of the Continental Association, and my own personal thanks to you all. And to Nasser, really, you have been the star for the Continental Association with all the excellent work that you have been doing for us and promoting not only Egyptian societies' excellent training opportunities, but also across the continent, bringing everyone together from North, West, Central, East, Southern Africa onto this platform. So once again, a shout out to you and your team, a shout out to the World Federation's Education Committee and its excellent team, and to the World Federation and the Foundation for the support that you have always provided our trainees and our training programs. So thanks very much for this opportunity and for your presence today.
Thank you very much, Mahmoud, for these kind words and for your welcome note. Now we start our scientific lectures. I think our first speaker, Professor Richard Byrne, he is Professor of Neurosurgery, Rush University Medical College at Chicago, and he is the Director of American Board of Neurological Surgeons. I would like to remind all speakers that for each speaker, there is 15 minutes, and we will make the discussion at the end of the webinar. I think we will have like 15 or 20 minutes for open discussion among all panelists. And for all attendees, please put your questions in the Q&A or in the chat, and we will monitor that through the panel. Thank you.
Great. Well, thank you very much for the invitation, and good morning from Chicago. It's an honor and a privilege to join you here today. I'll be providing a brief overview of patient safety, and then you're going to hear from our distinguished panel of world-renowned experts on safety within their fields. And I'm going to try to get my slides up here. If it doesn't go quite right, please let me know. All right, can you see the slides now?
Yes, Rich, is perfect. Thank you.
Thanks. I'm relatively new to Zoom. Our institution uses a different platform, so I'm going to try to get this right. As I pointed out, we're going to hear from 6 world experts in their own fields. I'm going to provide really just an overview and an introduction to safety in medicine. And as part of that introduction, I would just say that our obligations to our patients really are as follows: communication, education, compassion, treatment efficacy, safety, and safety comes with the old concept of first do no harm. The first do no harm goes all the way back to the ancient Greeks and Hippocrates. It was probably easier to say first do no harm 2,500 years ago because there was very little good that can be done either. In the modern era, so many of the things that we can do for our patients come with risk to harm and risk to safety. So much of what we do and the experience that we bring and that we teach our residents is in this balance between safety and efficacy. There's a saying by an old neurosurgeon here in the United States: if you're paralyzed by fear or hurting somebody, you're never going to help somebody. So you do have to balance this, and we balance it 100 times in every operation. We balance it before we operate, we balance it in our post-op care. So in that balance, you have the opportunity to rescue somebody, to be a hero. You see in this picture here, it looks like a relatively straightforward rescue. It looks like this is going to go well, but there's lots of risk even in this rescue. You can see that this person's hand might slip. They might lose grip of their protective device here. The person could fall while you're trying to save them. This is very, very familiar to neurosurgeons, and it goes back all through the history of neurosurgery. You see this crowd of people watching Harvey Cushing operate with a light bulb on his forehead. Nobody signed up for surgery with Harvey Cushing unless they were in a desperate scenario. And Harvey Cushing in our field was one of the first people to really balance this concept of safety and efficacy. And by the end of his career, the operations were much more efficacious and much safer. Right above Harvey Cushing here in white, you'll see this fellow Eric Oldberg, who was the first chairman of neurosurgery at our institution and brought these concepts to us. This is what my practice looked like. I do primarily gliomas. All day, every day, I'm balancing safety and efficacy, and experience really, really helps with that balance. And educating our residents about that balance is an important part of what we do. when I'm not doing gliomas, I'm doing a lot of skull-based surgery. There's no way that any one of these cases can be done without bringing some risk to safety. The concept of do no harm in reality is the concept of try to do no permanent harm. It's virtually impossible to do these cases without at least some temporary setback for a patient. So the modern version is really a balance between safety and efficacy. We have to make sure that whatever we're doing, if we're putting our patients through risk, we have to make sure that we're giving them some benefit for it. And that does bring about risk of harm. You'll hear a lot about that balance here today. Cases like this, I saw both of these patients in clinic on the same day, operated on them the next week. Obviously, there's a lot of risk to harm in these cases. The first patient above went home with no trouble whatsoever. The patient below did well with surgery, moderate hemiparesis. Post-op day 11 died of a pulmonary embolism. So it's not just about getting patients through surgery, it's about getting them home safely. And then doing a deep dive to figure out why in our system patients are getting pulmonary emboli and what can we do about it. So you'll be hearing all about these issues in the subspecialties of neurosurgery, and I'm looking forward to hearing these talks. On the bigger picture view, I know that in a World Fed webinar, there's going to be a lot of young leaders nationally, internationally, and these young leaders need to become safety advocates. This is something that's well known among our senior panel here, but in your medical center, you need to be a safety advocate. You need to advocate for subspecialization, multidisciplinary care, bringing the latest technology, not just the shiny technology that's good for marketing, but things that really work. You need to be involved in the operative process. You need to be involved in the preoperative and the postoperative care. You need to advocate for true safety data tracking, not urinary tract infection, line infection, and discharge length of stay, but what really matters to our patients about safety. And then you need to be involved in root cause analysis to find out why something went wrong. On the national scene, you need to advocate for regionally subspecialized centers. As I'll show you later, this really does matter. Become a political healthcare advocate for your patients. Be involved in resident education to bring safety to the next generation, and then be involved in CME and national and international organizations like we're doing today to advocate for safety. And then finally, beyond just certification for yourself and being involved in maintenance of certification, be involved in the process. Participate with your national board. Eventually try to become a part of your national board. Locally, you need to build your practice and your departments around safety. You need to make sure that everyone is planning. You're planning your department, everyone's planning their surgery, planning their practices out well. You need to protect against the highly improbable event. You need to make sure that you're as close to error-proof as possible, and then overprotect the really important issues. As far as technology goes, there's no doubt that advances in technology in the last 40 years have really made neurosurgery safer. And many of these advances in technology were invented by neurosurgeons. The ones here in yellow, invented by neurosurgeons. So going forward, it's clear that properly applied technology can lead to greater safety. Be a part of bringing that technology to our patients at the bedside. And then locally, you need to invest in the virtuous circle of subspecialization. There's no doubt that subspecialization leads to better outcomes, which leads to more patients, more experience, and then more capital for investment for more subspecialization. Make these arrangements, make these deals with your hospital administrators that you're going to super subspecialize, become better, get better outcomes. There'll be money to invest in data collection so you're really tracking what your outcomes are and making sure that it's as safe as possible. Advocate for multidisciplinary care and conferences. Our colleagues in allied arenas, ENT, neuro-oncology, radiation oncology, etc., know a lot. We can learn a lot from them, and we should work with them. When your administration tells you that it's too expensive to track safety events and so on, we're going to track satisfaction as a proxy for quality and safety. push back against that. There's plenty of data now in neurosurgery that patient satisfaction is not the same thing as safety or quality. This is a very important study here, prospective cohort of 418 patients, 75% survey participation. It's very rare to have a survey that's that robust. There was no correlation between satisfaction and major morbidity or complications. You just have to do the hard work of tracking your outcomes and tracking safety for your patients and then acting on it. And then invest in system process improvements and make safety less costly. This I call the second virtuous circle. So if you do prospective outcome evaluations, which we do routinely in our department, identify early problem areas and areas of strength, publish on what you're doing well, improve on what you're not doing well, create efficiency gains, there's going to be more savings to invest in data collection. We did this with our institution. We do this routinely. We find out what are we overspending on. We save money on that. We put that money back into our programs for our safety process improvements. Plan on being a high volume center. There's no doubt that quantity has a quality all its own. There's no doubt that high volume centers tend to do well by safety and quality outcomes. So if you take a look at across surgery, this has become very clear. In our field of neurosurgery, again, very clear. You can become a volume center by partnering with smaller hospitals regionally. This is what Chicago looks like. There's 75 hospitals in the 8-county region. We have transfer and co-caring arrangements with many, many centers. We take about 1,100 transfers a year, and that helps us to become a high volume center, which helps us to get better. And then on the national scene, we need to train for safety. We need to have safety embedded in the process of training. The Society of Neurological Surgery about 10 years ago created these boot camps, which you've probably heard of and you've probably instituted in your own countries. Boot camps training our residents the right way the first time, how to do the common procedures that they do that sound relatively simple, but as we all know, can go horribly wrong if done improperly. You see, it became apparent to us that in the continuum of clinical professional development, we were falling short on supervision in the PGY1 and early residency process. We upped that through our bootcamp training courses, and now instead of a PGY2, training a PGY1 on how to do these common procedures, and also just physicianship and professionalism, senior faculty are doing it in such a way that it's fun for both the faculty and the residents. Every resident in America comes to these courses. We added a second level resident course where 90% of the residents come for this course as well, teaching them some more advanced operating room skills and leadership. So in the continuum of clinical professional development, once you leave the bubble of graduate medical education, your learning curve is not over. You're continuing to learn about quality and safety. And I can tell you 23 years into my career, thousands of brain tumors later, I'm still learning something new every week. I make sure my residents know that the learning curve never goes away. We improve our process and our safety even after we finish our training. And that brings us to certification, my last point. We have to make sure that certification nationally is the first priority, is safety. We've changed some things in the AVNS. Our primary exam has changed, where questions are linked to a national curriculum which emphasizes safety. Our questions are becoming more clinically relevant. We added a neuroanatomy exam where the resident has to get 100% correct. We give them 3 source texts. They have to memorize them. We came to the conclusion that being 70% right in neuroanatomy is not acceptable. We have to be 100% right. Residents get 3 attempts to get to that 100%. But it is forcing our residents to be better and better in neuroanatomy. And then we changed our oral boards. We added a sequence where board applicants have to submit 125 sequential major operative cases with follow-up. and then we examine them on their own cases. This in and of itself has changed somewhat the practice of neurosurgery in the United States. We find that applicants for boards are becoming more thoughtful about what they're doing in that first and second year out, because in reality, you're done with your residency, but you're certainly not done in your learning curve. And they're more likely to get their senior partners involved in cases, or get that case to a regional referral center where they might get more subspecialized care. And then finally, maintenance of certification after you're certified. We've added patient safety modules, patient experience modules, and we're turning maintenance of certification from a periodic recertification into a continuous process that we do every year. In the end, all of these things that we do in the operating room, what we do systematically on the national and today the international level, are going to help to make our patients safer. So thank you very much.
Thank you very much, Professor Richard. As we have just said, we will keep discussion at the end of the webinar. Now we move to the second speaker, Professor Franco Servadier, President of the World Federation of Neurosurgical Societies. He is going to speak about the role of patient selection in head trauma surgery.
Professor Servadae, you need to unmute yourself. You're still muted. We cannot hear you.
Let's do it. Okay now?
Yes, thank you.
And this is the screen. It's okay now?
Yes.
Okay, then, okay. So thank you for the invitation. I have the role of speaking about the role of traumatic brain surgery and how do we select patients in trauma. This is a paper that we just published together with Miguel Arraez and many other friends from US and from the World Federation about the global neurosurgery. And these are the most common surgeries that are done all around the world. And as you see it here, traumatic brain injury is one of the most common surgeries. So surgery for traumatic brain injury is important all over the world, even in developing countries where in some places is even the first surgery. We just published together with our colleagues in Cambridge a paper showing how the publications are in one part of the world. You see it here. So Europe, East Coast of US, some Japan and China, but the traumas are in another part of the world. Usually the most common places for traumatic brain injury and road traffic accidents are Africa, Southeast Asia, and Latin America. So where the publication come from and where the traumas are located basically is different, unfortunately. We need to talk about surgery and indication for surgery. It seems that indication for surgery are easy in trauma. If there is a big lesion, we take it out and everything is clear. Actually, I will show you that a good decision sometimes is not easy. For the young neurosurgeon who are looking at this webinar, I wanted to tell you that there are 3 milestone papers published on surgery for trauma. One paper was published by the group of the European Brain Injury Consortium in 2005, and it was over 700 patients operated for trauma all over Europe. Then there are the guidelines that were produced by the WFNS and CNS joint section on trauma. I was honored to be part of it, 2006. And then in 2019, it's a report by the Center TBI study published in Acta Neurochirurgica discussing the variation in neurosurgical management of TBI in various parts, again, of Europe. So when I was telling you that one factor alone does not account as the main indication for surgery, you see how difficult it is for a neurosurgeon resident in duty to decide, because we do have clinical assessment of the patient with age and Glasgow Coma Score. We have a radiological assessment. We have a physiopathological whenever we have an ICP monitoring. So there are many factors we contribute to our decision. The main concept for the young neurosurgeon, since we never operate only because of one parameter. This was the disaster which the monitoring of ICP or intracranial pressure caused, where we tried repeatedly to show that it makes a difference and we were not able to do so. Only one parameter, even if important, will not be the main parameter. The example is the lesion. Lesion volume is one parameter in our decision. This is telling to everyone that we should operate every trauma hematoma who is over 25 millimeter. Doesn't mean anything. This patient has an hematoma of 140 millimeters volume, cc of volume, but this is not even transferred to neurosurgery. This patient is dying, and he actually died in 20 minutes. So we have to consider the condition of this patient, the age of this patient, apart from the lesion. Midline shifted is also extremely important. We know that small lesion with big shift have an underlying swelling, the swelling of an hemisphere, which is causing and compressing the brainstem. And it's important to operate these patients even if they have small hematomas. Then the most recent modern concept is the concept of evolution. We have a lesion, but the lesion usually in trauma, many lesions are not operated on arrival. They are observed. And whenever there is an evolution, they may change our opinion. And we know that acute epidural, acute subdural, and brain contusion can have an evolution within, let's say, 24, 48 hours from injury. But brain contusion can also evolve on the 5th and 4th day, meaning later. So brain contusion have two peaks and the other one only one peak. Epidural hematoma, this is a small epidural that none of us will think about operating, but the CT scan is obtained outside neurosurgery in another hospital who is about an hour drive from neurosurgery. And in a European course, we ask, should you transfer this patient to neurosurgery? Do you want to operate? If you don't operate, which is your advice? And the most interesting finding was that almost 50% of neurosurgeons say, no, the hematoma is small, you can keep in another hospital, 1 hour drive away, and you can repeat the CT scan. This was 3 hours later. So we know that epidural hematoma can evolve, and it is dangerous to leave the patients far away from a neurosurgical unit. So it is only a question, as I showed you, of the first 24 hours. Usually is an arterial bleeding. Whenever it's not bleeding in 24 hours, hardly it will bleed later. You see that this is a small epidural hematoma who did not bleed, was not bleeding, and you see that after 1 month and repeat CT scan, the hematoma is gone. So we know that if the hematoma is small, and these are the recommendation, if the hematoma is small and the thickness is even less than 15 millimeter, then we can not operate and observe the patients. This is interesting Chinese study showing us that if the CT scan is done within an hour from injury, the risk of enlargement is 10 times higher than if it is done 5 or 6 hours from injury. So what we know is the earlier the CT scan, the higher the risk of the hematoma injury. So the hematoma evolution. What about acute subdural hematoma? This is a recent Japanese paper showing that if we don't operate an acute subdural hematoma, the risk of enlargement is related to midline shift, to hematoma thickness, and to hematoma volume. But when you go into this paper and you see what they have published, then you see that they have treated conservative this hematoma, but this hematoma is already surgical. It's more than 10 millimeter, and the shift is significant. So this hematoma should not go in this way where the shift became almost life-threatening after 10 days. So you see that it's a mistake taking this hematoma for non-surgical. What about brain contusions? There are many papers showing us about contusional evolution. You see it here. You see that whenever we have a contusion to decide in favor of surgery, we need an increased ICP, clinical and radiological deterioration. So again, we use 3 parameters, not only one. We don't use only ICP, we use 3 parameters altogether. And you see it here. This is a paper that we published in the Journal of Neurosurgery in 2014 with more than 300 cases of contusion. And you see that the number of patients with radiological evolution is 200, but the number of patients with clinical deterioration is about half. So there is not a clear parallel between radiological and clinical evolution. So as you see it here, the most important factor for surgery in a multivariate analysis were midline shift and basal system compression. So apart from clinical evolution, not the volume of the lesion, as I've shown you before, but the compression of the lesion was mostly important to decide in favor of surgery. What about age? We all know that the age is bad. By increasing age, there is an increased possibility of bad outcomes. But this relation is not linear. It's just without a cutoff. We are not able to say anywhere that over 65, over 70, over 75, it changed. There is, by increasing age, there is an increased risk of a bad outcome. But as you see from this British paper, the typical situation that we have is that old patients have no access to neurosurgery. So whenever we need to transfer patients from another hospital, they are kept in the other hospital. So that's the effect of age is actually outside neurosurgery. The Glasgow Coma Score, it's important, but with the situation we have now in Europe with easy access to quick transport, we see that these patients are clearly with a similar small subdural hematoma and shift. We don't know anything about clinical assessment. They both have been taken to us, intubated and ventilated, but when we waked them up, we saw that one patient has a Glasgow 11 deteriorating, and the other one only 15. So it was perfectly awake. So what we have to understand that discussing about clinical indication, we need to know how is the clinical situation. Obviously, the two indications for surgery are totally different. So this patient cannot be operated only on the basis of a CT scan. We need to know how is it the clinical evolution. And the physiopathological issue, it's here. So you see it, how does it work here? So it's here, you see it. The last one is ICP. ICP can help us a lot, intracranial pressure, whenever we can do it, whenever we have the facilities. This is a patient who was operated because of a contusion and acute subdural, who had a post-op hematoma, and you see this was detected because of the high ICP, and the same here. Small contusion on arrival, ICP placed, repeat CT scan because ICP was increasing, and the patient improved after surgeries, but the patient was worsening. So what I'm telling you is this, that there is no magic ICP number. As I told you, we need for sure that ICP is put in a context. So in the context of our patient and other parameters, it's not the solely parameter. And this is the result of a survey, of a European survey. When you see green, you see that this parameter is important for surgery in trauma. High ICP and clinical condition, pupillary size and GCS are important. Guidelines is important, age is less important, and so on. So this still, whenever we work and operate our trauma patients. So I have just to finish that in surgery, there is still a gray area where the surgeon in duty decide without clear scientific evidence. But what we do is taking into account different parameters, not only one. In our and others' experience, midline shift and basal cistern compression on CT scan and a progressive clinical deterioration in both in pupils and GCS coupled together seems to be the most important parameters. Thank you very much.
Thank you very much, Franco, for this fascinating presentation. Now we are going to move to our next speaker, Professor Miguel Araiz. He's professor and chairman at the Department of Neurosurgery, Malaga University, Spain, and chairman of the WFNS Foundation and vice president of the World Academy of Neurological Surgery.
Hello, everybody. I hope you can see my screen. Can you hear me?
Yes, perfect.
Thank you very much. Thank you very much, Professor El-Ghandour, and thank you to the Egyptian Society of Neurosurgery. Thank you also to the WFNS Education and Training Committee, my dear friend Isabel Germano, for the kind invitation to participate in this educational meeting. My topic is about complications in skull-based surgery, and I just decided to focus in one of the main concerns as major vascular injury, basically carotid injury can be. If we look for complication in skull-base surgery through PubMed, we can see more than 10,000 published articles. And if we just focus in a skull-base surgery complication, we will see that more than 1/3 of the publication are related to this issue of complication in skull-base surgery, giving some idea about the real importance of that problem. If we look for carotid artery lesion, 1% of the complications are related to a carotid injury. So we are just in front of a big issue, a big problem in skull-base surgery. This is the Swiss cheese scheme according to which airplanes are crashing. There are some of circumstances leading to this problem, but in surgery, in skull-base surgery, I'm talking about carotid artery injury, we don't have, unfortunately, we don't have so many possibilities to avoid the problem. And just once the problem is coming up, the disaster is absolutely the consequence for the patient. We will put some example. This is case number 1. This is a patient with right optic nerve compression due to meningioma involving optic nerve at the optic canal. And this is, you can see the way of decompressing. We just elevate dura mater, and we just use, in that case, the ultrasonic drill. We are just opening the dura. You can see the infiltration. The tumor is surrounding the optic nerve, and in that moment, we are damaging the carotid artery. Actually, we are damaging the ophthalmic artery. We are at the right side, so ophthalmic artery is not supposed to exit at that point, but this is an educational course, and this example and the other one are mainly shown just to call the attention of the youngest colleague in the audience. What is the explanation for that problem that we fortunately managed to solve very easily? The problem is that there are anatomical variation in the origin of the ophthalmic artery. So one of the first comment is regarding the importance of the knowledge of anatomy in skull base, trying to avoid complication. So among all the possibilities for carotid artery injury related to anatomy, related to the lesion itself, to skill resources, and some high-risk situation. In that case, the lesion was related to anatomy, vessel wall abnormalities, and or anatomical variation. Let's see case number 2. Case number 2, this is a patient, 14 years old, coming from Central America, operated on in Granada, in my former institution, in 2000, by means of transmaxillary approach. It was about a chordoma. You can see the compression of the brainstem. You can see the extension of the lesion. And this is the postoperative MRI, nice sagittal view. Axial view is always mandatory to see until which extent the lesion has been or not completely removed. In that case, we have some remaining tumor that was removed by means of far lateral complementary approach. The patient was sent for radiotherapy, but the patient 14 years after came back with this recurrency. The patient underwent before that the radiotherapy, and the lesion was at the Petrus apex, as you can see here, and also at the parapharyngeal space, a complex lesion. You can see carotid artery, extra and intracranial at the Petrus region involved by the tumor. In that occasion, the previous case was, the previous tumor was operated on by means of transmaxillary approach. But in that case, we just had incorporated the endoscopic technique, and we did an endoscopic approach. But what happened is that during the drilling at the petrous apex, the carotid artery was damaged. We put a Foley balloon. You can see the Foley balloon. We took the patient to the angiography ward, and you can see the angio showing still some leak. And we just checked that there was fortunately a good collateral flow by means of communicating arteries, and carotid artery was sacrificed in that case, fortunately without any consequence for the patient. This is a problem that is related to the second main group of complication, pathology related, ICA, displacement by the lesion, adherence to the lesion to ICA that is not infrequent if the patient has just undergo previous extended surgery and or previous radiotherapy. And this case was falling into this 4-group high risk category due to encasement of ICA and the need of wide exposure, more than 2 segments of the internal carotid artery. Let's see case number 3. This is a patient operated on due to acromegaly. The patient had recurrence of the tumor. You can see the sagittal view. Can you imagine this anatomical difficulty to identify normal and abnormal structures? But this is very commonly seen after transsphenoidal and endoscopic surgery. So this is the view, not very good image, but the view of the surgical field. We do not use neuronavigation in de novo cases in pituitary surgery, very seldom, but we always use neuronavigation for recurrent cases. But in that case, the patient had been at the waiting list for a long time. The patient was already anesthetized, neuronavigation failed, but in any way we had to go ahead. We went ahead and see what happened. See what happened. Unfortunately, in one of these maneuvers, without much idea of where normal and abnormal anatomy was, we had a carotid injury. We just, it was very easily controlled, fortunately, by means of Flocil and tamponade, and the patient underwent CT scan, and you can see this pseudo-aneurysm at the internal carotid artery. There are several lesions taken from that. One of them is that you have to operate with a complete set of instruments and equipment, and in that case, it was my mistake to go ahead without the need neuronavigation provoking that lesion. This number 3 example is falling into this category. Could be inexperienced in skull-base surgery. I've been devoted to that field since more than 30 years ago, since the end of my training program. But in any way, it was my mistake to go ahead without the adequate and proper instrument and equipment. And I think there is also another comment regarding that case, is that in this patient we are seeing pseudoaneurysm due to manipulation and damage of the internal carotid artery. But we have to mention that this finding, I mean intracavernous asymptomatic aneurysm, is not infrequent. So we have to very carefully look at the MRI before surgery, because sometimes some asymptomatic lesion can be found during the operation. See case number 4. Case number 4 is a patient, 20 years old, with pituitary adenoma. And as I mentioned before, we almost never use neuronavigation in de novo cases, but there are several circumstances in that case. First of all, we are in front of a flat cella. This curve is not seen because you know that during endoscopic surgery we have some distortion of the 3D normal view, And also in this sagittal view, this is clear that when you get inside the sphenoidal sinus, you won't see any relevant landmark because you will see a flat bone. On top of that, see this asymmetric carotid artery. Reason why we just provoke some damage of the internal carotid artery. In that case, we should have also used neuronavigation. Fortunately, it was a lesion of the carotid artery, not much prominent, some laceration of the wall. Anyway, we took the patient to the angiography. You can see this narrowing at the angio due to intraluminal hematoma that fortunately didn't occlude the lumen of the vessel. And this is angio-MRI done the day after, showing some small images, but fortunately without any major involvement of the vessel. This is the angio-MRI done 1 month after, and this is 1 year after, an angio that was considered normal. Unfortunately, there was no consequence for the patient, but again, in this case, the problem and the complication came to the anatomy of the patient. In that case, due to the abnormality of the cellar anatomy, in that case, a flat cellar. There is some sort of publication regarding the management of the major carotid injury in endoscopic skull-base surgery. I very much recommend this paper from Dr. Paul Gardner and collaborator. And you can see this first summary regarding strategies for the control of the carotid artery injury. First of all, let's mention the sacrifice of the carotid artery. Approximately in 80% of the patient is very well tolerated. Important to mention that the role of the BTO is very important. I have to confess that before the review of all these problems, all these are personal cases, so personal complication. And before this review, I did not take into consideration the need of BTO in certain cases. So I do recommend to very much and very carefully review all your cases and take into consideration the BTO, maybe not in pituitary surgery, because carotid injury is not very frequent, but in some other cases of major skull-base surgery, endoscopic or not involving carotid artery must be considered. Just link to that the need of bypass prophylactic of emergent. We have never done that, and we have never considered the possibility of emergent bypass, but this is something to think about, although set up for that emergent bypass operation is very demanding. Very important point number 3, vessel preservation techniques. Bipolar electrocautery. Bipolar coagulation can be done if you are dealing with a small vessel coming off the carotid artery, for instance, some pituitary artery. If the lesion is over 3 millimeters, you cannot try bipolar electrocautery because you will impair the situation of the carotid injury. Aneurysm clips is a possibility. In our cases, very never considered due to the situation inside the clinical the surgical battle. Let's say we did not consider this possibility. That is not easy. You have to have exposed at least some segment of the carotid artery before putting the clip, and sometimes you provoke the rupture without having any exposition, enough exposition for clipping. Very important, packing. Packing should be the initial measure. What kind of substance? Among all the substance, muscle is number 1, just in order to do this packing. So take that into consideration. And talking about suture, this possibility when dealing with patient by means of endoscopic skull-base surgery. I think this is something not feasible in many instances. So we do not take, in our cases, we didn't take that into consideration. Very important, the summary regarding endoscopic skull-base surgery, injury of the internal carotid artery, direct injury laceration, small, tri-bipolar or clip, large occlusion of muscle pack. If there is a perforator avulsion, as I mentioned before, coagulation is the ideal solution, and in any way the patient should be taken to the angiography ward. Some comments regarding endovascular management we have seen in our cases, going through the different possibilities. One of them, when you have active extravasation, that was case number 2, pseudoaneurysm, and also ICI stenosis that may come from packing, excessive packing, or intraluminal hematoma, as it was in our case. I have 2 more cases to finish, not related to endoscopic skull-base surgery. This is a patient operated on by means of pituitary surgery and transcranial surgery, and also the patient had been irradiated, a young patient with, again, this recurrency of craniopharyngioma. Of course, we had to operate the patient, but we had to make the choice, transsphenoidal or transcranial. We made the decision of transcranial surgery after looking at this image. You can see the cyst, and you can see this is the anterior communicating artery region, and see the encasement of the lesion that is not unfrequently seen when the patient previously underwent surgery and or radiotherapy. And see what happened. We in that case, we managed the patient by means of interhemispheric subfrontal approach that in complex cases, to our mind, is the most appropriate route, because you are going to see the lesion from abroad and having pure midline view of the lesion. And this is the view, and see what happened in this indolent maneuver. Immediately, carotid artery was ruptured. We managed to control, but unfortunately the patient underwent hemispheric infarction, needing decompressive craniotomy. According to our way of considering craniopharyngioma management, let's see that carotid artery damage is more frequently seen after previous operation and radiotherapy, and to our understanding of the surgical management, we do open skull-base surgery, we do also endoscopic skull-base surgery, but in cases like that, we understand that the much better control is achieved when dealing with the patient by means of open surgery. And this is important to mention that also this decision of doing craniotomy in that patient comes from our general overview of the management of craniopharyngioma, taking into account the age, hypothalamic involvement, intracellular, intracranial, transsphenoidal craniotomy, partial removal, and so on. So let's focus in this 3 part, whether the patient underwent radiotherapy or not, previous craniotomy or not, previous radiotherapy and craniotomy. According to our scheme, this is our personal view, if the patient underwent radiotherapy and previous craniotomy or previous craniotomy, we go back to the case by means of craniotomy. If the patient only underwent transsphenoidal surgery, you can make the choice of endoscopic skull-base surgery. So in that case, the complication came also from pathology-related issues due to displacement, adherence to ICA due to previous extended surgery and previous radiotherapy. And let's move to the last example, case number C. This is another possibility. This is a young patient, 12 years old patient with this huge bony tumor that was unfortunately a malignant sarcoma, see the encasements of the carotid artery, see the highly vascular lesion, not amenable of complete endovascular obliteration. This is an intraoperative view. This patient was operated on maybe 17 years ago or something like that. This is the extended subfrontal approach, optic nerve decompression, both frontal lobes, and the lesion partially removed, but taking into account that if you have a major vessel encasement, bilateral major vessel encasement, high vascularization, intraoperative bleeding, very frequently the patient has, let's say, important episodes of hypotension that may lead to, again, hemispheric infarction. So take into consideration this possibility. So my last slide is about some comments regarding avoidance and management in ICA injury. First of all, to take into account variation in anatomy, to take into account the tumor characteristics that may displace or invade a carotid artery, making the identification of the anatomical situation and the surgical management of the ICA difficult. We have seen the strategies in case of rupture. I'd like to highlight the issue of muscle as the best hemostatic agents for parking. And just finally, just to mention that the role of endovascular management is crucial to manage certain lesions, as we have seen before. The reason why I think that it's mandatory to have this facility nearby when dealing with a complex skull-based lesion. And I like to finish the presentation, but not before that. I like to thank again my very good friend, Professor El-Ghandour, Professor Isabel Germano, the co-moderator, Dr. Qureshi, the kind invitation and the kind attention to my talk. As Professor Servadei, our president of WFNS, mentioned, we are in a new time and we are taking advantage of the possibility of webinar. Unfortunately, we cannot see each other, have a cup of coffee, shake our hands, but I hope we can do that in the next future, and I will be waiting for you in the beautiful Malaga. Thank you very much.
Thank you very much, Miguel, for this great presentation. And thank you very much for contribution to this important symposium. I think we can have one question related to your topic. I just have it now in the panel. What are the possible ways to open the stenosed internal carotid artery in such cases?
Well, I think that if you have carotid stenosis, usually is due to overpacking, because sometimes packing is kept for several hours or maybe 24 hours. So one possibility is occlusion of the vessel due to overpacking. Second possibility, so if you diagnose that, it's very straightforward that you have to remove the packing. And second possibility is intraluminal hematoma. In cases like that, the only option could be stenting, but I have to say that according to our experience, unfortunately, we have that experience, I have honestly shown, according to our experience and management of our cases, if the lesion is at the cavernous sinus, due to the shape of the carotid artery, is not easy the placement of stenting. So stenting is the ideal way of giving permanent solution to the occlusion or reduction of the lumen of the vessel, but sometimes it's not easy.
Thank you, Professor Miguel. Now we move to the next speaker, Professor Dr. Youssef Bouzoba, consultant neurosurgeon from Morocco and is a member in the Education and Training Committee, WFNS, is going to speak about the wrong side and site in spine surgery.
Thank you. Thank you, Professor Nasser El-Ghandour. You hear me?
Yes.
Thank you. My dear colleagues, yesterday was a World Patient Safety Day. It's perhaps a coincidence. But first, I would like to thank the organizer, Professor Servadi, Professor Germano, Professor Qureshi, and Professor El-Ghandour for their effort. My talk is on the wrong side and side in spine surgery. Performing a wrong side and side surgery, it's harmful for the patient.
Yusuf, can you share your slides, please?
Excuse. Yeah.
There is a screen, share screen button, green one below you in the bottom. Say share screen is green in the bottom. You have to fix it.
Yes, I have push it.
Ma dove ti sei? Oh, ecco. Dove ti eri messa? Che si vedeva. A te?
Can you see?
Insomma. No, te non ti sei mossa, ma si è mosso il computer e si è visto te.
Okay, you need to mute yourself.
You heard me? You see
Yes,
my...
We
No?
see and we hear. Perfect. Thank you.
Okay. I come back, huh? Excuse me for these technical issues. I had said, dear colleagues, yesterday was a World Patient Safety Day. It's perhaps a coincidence. And I would like to thank the organizer, Professor Servadi, Professor Germano, Professor Qureshi, and Professor El-Ghandour for their effort. My talk is on a wrong side and side in spine surgery. Performing a wrong side or side surgery is harmful for the patient. It's a nightmare for the surgeon with disastrous consequences as multiple surgery, deterioration in a relation between surgeon and patient, and this can lead to medical lawsuits. Excuse me, there are also some problems. The wrong site surgery is one of the never event and is the most common sentinel one. Dear colleagues, have you had such issues? If yes, you aren't the only one. If no, this issue is underreported and is a taboo subject. 45% of medical error occur in the operating room and are preventable. The North American Spine Society report 68% of had performed the wrong level among 173 responders. In a national survey in Canada concerning wrong level discectomy, the rate seems to be low, but it should be near zero. The Joint Commission of Accreditation of Healthcare Organization reports that among about 400 spine surgeons, 200 had performed surgery on a wrong level at least twice. I had launched a survey, a brief survey, and simple, easy to fill, from neurosurgeon, from CANS, Pan-Arab Neurosurgical Society, French-speaking society, and Mediterranean Association Society. About half of them had site or side issues. To define a wrong level is not easy. When the surgeon checks during surgery and corrects himself the wrong level, does he harm the patient? We can argue yes, but the degree of harm depends on at what stage the surgeon corrects his mistake. It was during muscle disinsertion, or when removing ligament flavum, or at the stage of discectomy, or even at the end of surgery. Another question, should we consider violation of pedicle when performing osteosynthesis as a wrong level surgery? Dear colleagues, many factors can lead to a wrong site or wrong side surgery. Many mistakes could happen from doctor's office to the operating room. As makes a report of patient information, we should control and check the radiological finding. In our survey, 60% of responders don't read the full radiological report. So there are a lack of communication with the radiologist. There are also a lack to respect the adapted policy derived from the universal protocol for preventing a wrong site and a wrong procedure and a wrong person surgery. In a recent study, there is no evidence to support the Joint Commission checklist, the North American Spine Society checklist, or others preventive measures with respect to their effectiveness in preventing a wrong level in spine surgery. In our survey, more than half of responders don't respect any policy. Fluoroscopy and radiography are important to consider. We perform usually a lateral view during surgery, but anterior-posterior view is very important to consider. Poor intraoperative imaging can result from technical issues and competence of the technician, but also due to the analysis of some anatomical region as the cervicothoracic junction or some anatomical variation. We report that he had performed 5 wrong level when operating 42 transitional lumbar vertebra for discectomy. The different coaching techniques is important. Radiologists, when performing MRI, count from C2 to sacrum. But surgeon, during its surgery, he performed fluoroscopy and count from sacrum to C2. As we see in this slide, if we count from the top, this lesion is as T7. But due to some anatomical variation, if we count from the sacrum, this lesion is at T8. Other reasons are obesity, short neck, osteoporosis, great deformity, and previous surgery. Other factors, some even ridiculous, but reported as reverse the film on the X-ray box, unusual operating theater, or when performing emergent techniques. Does the resident had more wrong level than experienced surgeon? The answer is no. But in the academic institution and large hospital, in spite of many doctors, the rate is higher. Fatigue could lead to burnout is important, and we will see that later. Zero event is the goal, and all cases should be preventable. The universal protocol for preventing wrong procedure is a consensus of 40 medical associations and require active and effective communication of all members of the surgical team. Require also involvement of the patient or the legal representative. It should be flexible in order to be adapted to each institution. The universal protocol include some important caution as marking operative site, light left with a permanent marker. Surgeon should participate when positioning the patient, and time out immediately before starting surgery is paramount. Here we see the WHO safety checklist, which predict a reduction of morbidity and mortality when it is respected. It's include before incision anesthesia, before skin incision, and before patient leaves operating room. Fluoroscopy and radiography are the most used device as we see in our survey. But other sophisticated technique as arm spinal navigation, aero intraoperative CT-based spinal navigation, and other sophisticated technical are in process are very helpful. Some procedures are important as this device sets cervical visualization. It's allowed to perform a transient caudal shoulder displacement in order to visualize the cervicodorsal junction, as we see in this slide. Other procedure could be helpful are the preoperative percutaneous localization using fiducial screw or preoperative colocalization, in addition to preoperative vertebroplasty and radio-opaque skin marker. During surgery, we perform fluoroscopy or X-plane radiography, which identify easily the right level. The minimal invasive spine surgery reduces the nightmare of the wrong level. The answer is yes, but there is a relative increase of radiation. As a doctor, we have many responsibilities, and we should not only improve our technical skills, but also be aware on other aspects as ethics and medical legal responsibilities. We should reduce medical legal procedure in order to protect neurosurgery from one of its three enemies, as that had been said during the interim meeting in Roma held on 2015. One of the enemies of neurosurgery is the medical legal litigation, and we should reduce that. For that, I want to just remember some statements from the WFNS and some recommendation. Ethical guide to which is an ethical guide to remind to neurosurgeons worldwide our commitment to the patient and communities we serve. Primum non nocere is a well-known concept that one must bear in mind that there is no intervention that does not have some slight risk. In the chapter related to a relationship with patient and family member, it's stated we should be honest with patient and their families about the reason for complication and express our sincere regret when the situation does not go according to plan. Neurosurgeons should avoid overwork to the level that it leads to excessive tiredness or stress and thus diminish competence. In this survey, are physicians severely depressed? The answer is physicians suffer from clinical depression in about 20% of cases. Does the depression affect patient care? And we see here that the answer, I make error that I might not ordinarily make in 14% of case, and I make error that could harm patient in 5% of cases. Since the publication of the Institute of Medicine report To Err is Human, many efforts have been made in order to reduce some major errors as a wrong site, which represent 22% of the major error. And at this occasion, the Joint Commission recommend these evidence-based approaches, which include intraoperative confirmation, marking the site, and a team work. In a study, patients haven't not been informed on a wrong side, on a wrong level, in spite of some bad result attributed to the failed back surgery syndrome. In a medical legal study, 90% of a wrong level ended up in litigation. 54% settled out of court, but at the price of a costly indemnity. In another medical legal study on herniation disc disease, there were 13 defense verdicts on 65 lawsuits. And it's recommended to inform a patient on the risk factor in case of special circumstances exist. In case of performing a wrong level or wrong side surgery, we should recognize, inform patient family soon, offer to perform the correct level surgery if patient accepts. High lie is unethical and indefensible. I have some reflection. In a case of medical mistakes are not only the medical mistakes are not only the result of human and inhuman error, but it could be due to the availability of research, professional culture, public perception, and medical legal environment. The second reflection, according to the Joint Commission, wrong level or wrong side surgery is a team responsibility, but spine surgeon is still the only one responsible. Third reflection, should we consider a wrong level similar to a wrong side? A wrong side surgery is a never event with disastrous medical legal consequences, and a wrong level is a specific issue in spine surgery and could be considered quite different from the wrong side comparing to other surgical specialties. In our survey, about 1/4 of responders had medical legal litigation. And here I have some comment from the responder. As long as you have not found what you are looking for, consider that you are wrong. The second comment is, I have had in over 30 years of practice 2 cases of level errors in the median thoracic level despite the use of fluoroscopy, requiring revision without adverse medical or legal consequence. At the conclusion, there is no simple case in spine surgery. We should care on the level and on the side, identify difficulties, especially in thoracic level, or in case of their anatomical variation, obesity, previous surgery, great deformity. We should use preoperative tips when needed and develop a close collaboration with the radiologist. Teamwork, time-out checklists, respect are key factors. Patients should be informed in case of difficulties and don't hide, don't lie to the patient. My last message is to the WFNS spine section, how to define a wrong level and try to answer the questions. Does a wrong level is equal to wrong side, especially regarding the medical legal consequences? Thank you for your attention.
Thank you, Yusuf, for your presentation. I think for the interest of time, we have to move to our next speaker. Next speaker is going to be Professor Isabel Germano. She is Professor of Neurosurgery and Director of the Brain Tumor Program, Co-Director of Radiosurgery Program at Mount Sinai Medical Center in New York. She's also the Chairman of the Education and Training Committee of the World Federation of Neurosurgical Societies. She's going to speak about technology in brain tumor surgery, how to avoid pitfalls.
Good morning again. Thank you very much, Professor El-Ghandour, for the introduction. I think that the theme of the day is really how to avoid complications and how to preserve safety. And as we have already heard from previous speakers, sometimes we think that introducing technology into the operating room is really the panacea from resolving the safety issue. And today I would like to share with you my experience with technology in the field that I practice, and that is brain tumor, and to make us all think that technology is here to stay. Technology is good, but we also need to be aware that even with technology, we can actually make errors. So primary brain tumors are an important aspect of neurosurgery. As you can see in the slide, primary brain tumors are among the top 10 causes of cancer-related death in the US. And I think that this figure is increasing across the world as the neurosurgical care is enhancing. In 2020, here are the numbers that we can quote for the United States. We're a little behind in statistical analysis, but you can see that in 2018 there were over 80,000, and similarly in 2019 there were over 170,000 new cases of brain metastasis per year. So it's definitely a disease that we all need to be familiar with, and there are many more neurosurgeons across the world that are practicing brain tumor surgery. We need to remember that as neurosurgeons, we have three potential ways that we can help our patients. One is to reduce the number of deaths that are occurring from brain tumors, and sometimes we can for both gliomas and metastatic disease. The other very important aspect is that we can decrease the neurological disability. And that can be done if we really understand the anatomy of the brain, if we rely on technology, and if we understand that there are some limitations of technology. So has been shown over and over again that if we perform an aggressive resection of a primary brain tumor, the patients are doing better, meaning that they survive longer. And this has been shown approximately starting from 10 years ago, and then now there are more robust studies confirming that the original hypothesis and the original class 2 study, evidence 2 studies are actually correct. And so how do we do that? How do we really perform these aggressive resections to improve the outcome of our patients? And I think that technology is very important. We use technology as preoperative assessment, and we use technology intraoperatively. And I would like to kind of show you a few things that in my practice made me raise my eyebrows a few times. And so I will share with you my experience in the field. And I've been doing this for more than 20 years. So when we look at brain tumors, I think that the most challenging tumors are those that are in eloquent areas. And the best definition for eloquent brain is that of a part of the brain for which other structures cannot take up function in the event of an injury. It's a part of the brain where there is limited plasticity. And this concept is true not just for brain tumors, but also for other kind of neurosurgical operations, such as epilepsy and arteriovenous malformations. And so before we tackle a brain tumor, we do review the preoperative images. And sometimes it's pretty straightforward. This is a paper that was published by Dr. Berger in 1990, where he was pointing out eloquently always to look at the contralateral side of where your lesion is to recognize where a central sulcus is, and then go on the side where the tumor is and kind of try to extrapolate where that is. It could be displaced forward or backward, depending on the extent of the mass. But you can see that in a case like this, you can see that this tumor is pretty well circumscribed. It is anterior to the motor cortex. And so that technology is going to be important during the resection. However, you also need to have this anatomical picture in mind. And I think what Dr. Byrne showed us, that we need to be 100% sure with our anatomical markings is very, very true, because we can use technology only if we have that anatomical understanding. If we don't have that anatomical understanding, then the technology can be wrong and can lead us into deeper issues. And clearly this is different to this kind of tumor where there is infiltration of the primary motor cortex, and this is clearly a case that will need much more intraoperative confirmation. And so here is another example, right? This patient, as you can see, has a motor deficit. She also has difficulty articulating words. And in this particular case, what it shows is that the tumor is basically nested between Broca and between the homunculus and the motor cortex. And most likely the reason why she cannot articulate those words is because of the compression over the facial phonation muscles. And in these cases, we want to get more knowledge prior to surgery. And one technique that we use oftentimes is the functional MRI. And is functional MRI really reliable? And here is a very important concept to absorb. Functional MRI is based on the BOLD principle, the blood oxygen level dependent. So what that means is that in the activated areas, there is an increase of flow that causes an increase of oxygen consumption and a decrease of deoxyhemoglobin. And it's the relative increase in oxy-deoxy level that correlates with the T2 relaxation times and gives us those pictures that actually don't come out in colors, they come out in black and white, and then our physicists are changing into colors. So here is already the first inaccuracy, whether or not those images are really rendered accurately, and in most software this is now pretty good. However, the other possibility is, could the impaired autoregulation near brain tumors make functional MRI inaccurate? And this is what the literature is showing us, that the concordance between the functional MRI and the intraoperative cortical stimulation ranges between 61 and 100%. Now, if you throw the 100% in the garbage, because it's very hard to have 100% in medicine if you do a lot, right? So let's say that is 99%. You're still left with the fact that in some institutions, you have a 61% concordance. 61 is really not good. We had mentioned that we want to be all the way up to the 99 to 100% level. And the range of accuracy is 5 to 15 millimeters. So for brain tumors, we have shown that if you are in the 12 millimeter range, you can cause an anatomical deficit and neurophysiological deficit that is irreversible. And so if the range of accuracy of your functional MRI is 15 millimeters, what it means is that if you use functional MRI for your guidance, you might unfortunately injure that patient. So it is very, very important to keep these numbers in mind and to develop your own experience, especially if you start using functional MRI in your institution, because you might be under the wrong impression that because you use functional MRI, that your surgeries are going to be risk-free, and that is not the case. The other thing that is very sexy is DTI or tractography. Everybody wants to have DTIs. There are multiple industries that are making tons of money in trying to convince us that if you use DTI, your surgeries are going to be safer. And this is something that still needs to be proved. And why is that? Well, because once again, these images are images that are obtained using isotropic and anisotropic HO2 diffusions. And by rendering this with a mathematical, very complicated formula, you have this black and white images that then are rendered in color. And there again is one possibility for error. But and here is the mathematical formulas where we look at three different dimensions: the spherical, the oblate, and the prolate for the DTIs. But look at this beautiful study that was done by Sonia Pujol in 2014. She sent the same data analysis to 10 different major medical centers in the US. And this is the rendering of the pyramidal tract that was done by different institutions. So if you're doing the surgery of this tumor that you can see in green, which of these you're going to believe, right? And so if you really only base your resection on those DTIs, you could be totally off. I mean, look at the difference between this institution that has this very tiny, teeny pyramidal tract and this one that has the tract that is surrounding the entire tumor, which is right and which is wrong. And this is something that each of us in our own institutions have to prove over and over again until when we reach some sense of what our software is all about and what our intraoperative recording is all about. these images, the DTIs, can also be imported in the navigators. And so then if you use them intraoperatively, again, you might really lead yourself into errors because the interpretation of this could be totally inaccurate. Talking about neuronavigation, neuronavigation is great. We introduced it in the way of the optical digitizers in the US. I was the first user of the optical digitizer. And I think that we've shown and others shown that if you can remove the tumors using microsurgical dissection, using a neuronavigator, you will decrease your length of stay, you will decrease the neurological deficits. And in case of metastatic disease, Dr. Sawaya showed that you also decrease the leptomeningeal disease. And here is an example of a tumor depth that we localize, although we cannot see it in the surface. We do a front sulcal resection without interfering with the cortex, so there is really no need for any monitoring because we're not entering the cortex, and beside the fact that the location probably doesn't support that. And then we remove the tumor unblock, right? But neuronavigation can be off. And I had multiple, because I started in a sense the field, I have multiple constant requests from either industry or colleagues or the medical legal. The stealth or whichever equipment was used was wrong. And the answer is, unfortunately, we cannot say that the equipment was wrong. It's what we do that is wrong. One of my mentors had this great sentence that he liked to say all the time, and that was, a fool with a tool is still a fool. And what that means is that unless we understand the limitations, we really do not help our patients. So for neuronavigation, there are very simple things that can be done to reduce this error. And we published some of those, and here in the table. If you have a cystic lesion, clearly you don't penetrate the lesion. Once the lesion is leaking out, then clearly your coordinates are off. If you use mannitol, there is brain shift that happens. So in my cases, I never use mannitol, I only use hyperventilation. If you use CSF diversion, unless you are going for a skull-based lesion where then the anatomical landmarks will not move because the bone doesn't move. But other than that, if you use CSF diversion, clearly you're off. And then if you're positioning in extreme position, like extreme lateral, the gravity vector will work against you, right? And brain shift does happen, even if you don't do anything. This is a great picture showing that just by virtue of opening the dura, if you set the microscope on the surface of the brain, it will be off focus within minutes. And there is also another thing that we and others have shown, and that is that if the tumor is a large tumor, and in our study was 30 cc's, those tumors, unfortunately, are difficult to really re-navigate, and you can leave a residual, just like we did here over time. And that needs to be updated. So those surgeries, we had introduced the coupling of the ultrasound with the neuronavigator. Ultrasound is a relatively cheap technology that is very reliable if you do understand the concept of echogeneity and the concept that if you put the probe perpendicular, you see what is below it. So here's before the resection with the echogeneity, and here is after the resection without the echogeneity. But if you don't put the probe perfectly perpendicular, and if you're uncinnating something else, then again, it could give you the sense of false safety. And also other things that we and others introduce, for instance, the 5-LAA for resection of brain tumors. If you're really only taking out the very bright pink, then most likely 97%, you are in a tumoral area. But when you start going around the periphery, whether or not that is tumor for infiltrating brain tumors, naturally there is always tumor no matter where you are. But if it's really necessary to go above and beyond, is something that is still being studied. And therefore this technology can give you the sense of false security to be too aggressive and then get yourself in trouble because you're chasing quote unquote tumor in eloquent areas. And let's look now at monitoring and mapping. Age selections is very important, as Professor Servadei taught us beautifully this morning, this afternoon, about patient selection for head trauma. Also for these techniques, we have to be selective. If the patient is less than 5 years of age, the cortex is not excitable, and therefore somatosensory evoked potential will be the way to do it. Neurological deficit, right? So if the patient has a baseline error that is greater than 25%, most likely when you put the patient on the table and you try to do your speech mapping, it will just be garbage in, garbage out, because the error is going to be even greater. And so then you will be in a situation where you said, but I did use the mapping, and the patient woke up and couldn't speak. So we have to be aware that that is really not the technology, but is us not understanding the limitation. And similarly, if the patient has a dense hemiparesis, if you map their motor cortex, you're not really gonna get much out of that. So let's look at direct stimulation. For language, we need to understand that what we are eliciting is what we are mapping. So if we ask the patient count 1, 2, 3, and then we cut the tumor in the area where the patient was still able to say 1, 2, 3. What we did was mapping the essential part of the language. So that patient can still wake up from surgery and have a language deficit, but it's language that we didn't map, right? So we map something very essential, but language is much more complex than that. The other thing that is, I think, very important to keep in mind is the electrical spread. And so that if you're stimulating this gyrus, but your current is too high, you're actually exciting the gyrus nearby because of the U fibers. And so it gives you the wrong information. And then one thing that I think is very important is that, especially when you start doing these cases, it's important to have larger openings, because you need to confirm a positive response, so that then when you have lack of response, that lack of response is more predictable of the truth. If you only have negative responses, especially when you start this, you don't know if what you're doing is actually correct. And so that's what we like to do for our parameters. We really drive the current all the way up to have the after discharges, and then we decrease it right below where the after discharges were obtained. And clearly no paralytic agents needs to be used. Very simple device. This is the Ogerman cortical stimulator. And let's look at SSCP. I use SSCP a lot. I think that is a great way to confirm the position of central sulcus. But again, if there is a sensory deficit that is present, that are not reliable, because this technology is secondary to the difference between the responses across the sensory cortex. So if you have a deficit in the sensory arena, then clearly this cannot be used reliably. And so in conclusion, I would like to suggest that technology is and will be part of our neurosurgery armamentarium, particular for brain tumors. Technology can really help us performing better surgeries. However, it is very important for us to understand the possible pitfalls. And if we do understand those, we can perform safer surgery. And if we continue to learn the anatomy and are 100% on that anatomy, we might be better surgeons with the same technology. Thank you for your attention.
Thank you very much, Isabel, for this great presentation. And now it's time to move to our next speaker, Dr. Suad Bakhti. She is president of the Algerian Society of Neurosurgery, and she is secretary of the Pan-Arab Neurosurgical Society as well. She is going to speak about age and other safety parameters in pediatric neurosurgery.
Is it okay?
Yes.
Okay, thank you.
Thank you.
Dear colleagues, first of all, it's a great honor, a pleasure to be here, to be a part of this educational symposium. And I want to thank and congratulate the organizers, with particularly my friend Nasser El-Ghandour, Professor Mahmoud Qureshi, and my friend Isabel. So I will try to talk about safety in pediatric neurosurgery and keep on time, because we have so many things to say about that in this field. And as everybody knows, the child is not only a small adult, but furthermore, you can see that we have several categories of children, and from the premature to the adolescent, and which is very important to emphasize is that developing structures in children are more vulnerable to injury than developed structures in adults, especially regarding small and deep targets. So I can talk about parameters, but I want to say that we have to look at many things: the patient, the disease, the tools, and so on. And the parameters can be dependent one from another, and we have to consider safety in and post-operative period. So let's talk about the patient. Of course, for the patient, the first parameter is the age, and you can see that each category of age has his specificity in disease and also in matter of concern. For example, the prematures have the big problem of organ maturity. For the newborns and the toddlers, the problem also is blood loss and thermoregulation. And sometimes we forget something very, very basic, which is the brittle of bones. And some people are using still now using fixing headrest, and which may cause very bad complications such as fractures, epidural hematoma, and even abscess. So the conditions of the patients also are to take in consideration, and we have to look at many things. And as we know, the most of the children are in low and medium income countries, and in these countries, malnutrition is very frequent. So malnutrition can threaten the safety of our patient. Also, we have to deal with associated pathologies such as the diabetes or sickle cell anemia in Moyamoya syndrome. And also we have to look if, when we are faced to a brain tumor, if we have an associated or disease or syndrome that predispose to CNS tumors, which maybe sometimes will guide the management. The disease itself, sometimes, of course, the location is very important to consider when we talk about safety, but sometimes you will receive huge tumors because of delayed diagnosis. And often the children will be in poor conditions, such as in this photo. And I must say that in our department, we have a policy when we have to deal with children in very poor condition, we prefer to perform the surgery in 2 times. We consider that it is safer for the patient. For example, this young baby that was arrived in very, very poor conditions, we have operated him in 2 times, and it was a pilocytic astrocytoma, and everything was good in post-operative period. For the malformations also, very often in low and medium income countries, we have to deal with myelose, but they arrived lately to a center of neurosurgery, and it means that we will have higher infections rates and also difficulties to closure, which means dehiscence of the skin, CSF leak, so many morbidity and even mortality in relationship with this delayed management, and this also will threaten the safety of the patient. The skills of the team. Skills of the team is very important. You need for safety in pediatric neurosurgery, pediatric anesthesiologist. And unfortunately, it is not always available in low and medium income countries. And even if you have them, they are not very skilled in prematures and newborns. Also, you need to have skilled pediatric neurosurgeons. And this very nice paper of Albright concerning brain tumors, we know that pediatric neurosurgeons that are using that are operate very often to brain tumors will achieve better safe maximal resection with minimum of morbidity and mortality. How to get skills in pediatric neurosurgery. I think that many of you have talked about that. It's the training with the classical way, of course, but with the new tools, which are the simulation and the models. But unfortunately, also cadaveric dissection will help, but unfortunately, these three kind of training will be very limited in low and medium income countries, because they are, sometimes it is not allowed as in my country, and sometimes it is expensive. So I hope that in the future we will have more and more simulation and models that will be accessible. Blood loss, we have to talk about some consideration in the children. The blood loss, you can see what are the problem of CBF in children, and you can have also tools to avoid, to limit the blood loss, such as tranexamic acid in craniosynostosis, and for example, also when you have post-traumatic scalp in young babies, you can do also protocols of massive transfusion with good results. The fluid and electrolyte management also is a matter of concern, because if you don't manage correctly that, you will have severe morbidity and even mortality, and you should be careful with hyponatremia, which can cause very, very big problems. And at the end, the key of success of a team like this is the communication. And you can see one of my surgeons and one of my anesthesiologists who are very close and doing a very good job. The tools. For explorations, of course, I have to say one word about endocrinologic assessment, which will allow to recognize and correct many endocrinologic deficits that can be deleterious in the postoperative period, such as in craniopharyngioma. For imaging, I think that at least we must have a good MRI with all sequences. I don't know about spectroscopy in pediatric neurosurgery if it's really important, but maybe also DTI can be helpful for thalamic lesions, but Isabel have talked about the mistakes that we can have with DTI. Places, I have to talk about places because maybe it's evident for developed countries, but in developing countries it's not evident. So we have to have a specific aseptic operative theater and also an intensive care unit. It is very important, and sometimes it's not available in some countries. For the operative tools, of course, the microscope is mandatory. We have talked about navigation and the problem of shift. And also for imaging, perioperative imaging for extension of resection, we have to deal between ultrasound and MRI. Everybody knows that MRI is very, very expensive, and not all the developed countries have in their department perioperative MRI, but ultrasound is, I think, a good investment, can be used in real time, and also can be used with other technologies. What about ION? ION, with this very beautiful paper of the team of Shlomi Constantini, can have a role even in infants. But I think, and this is everybody thinks that we can't do all the ION that we practice in adult in children. And of course, we need more and more studies to assess the valuability of ION in very young children. The awake surgery, Isabel talked about it, but it is always under debate in children because first of all, we don't have many tumors in eloquent areas. And secondly, we are always afraid about the psychological aspect in children, but it seems that with a good psychological preparation, we could achieve good results, and we can also adjunct hypnosis. Of course, robo-assisted procedures in pediatric neurosurgery is in continuous improvement. It can enhance the surgeon's skills. And you can see on this slide that it can be easy to make an endoscope on robotic arms and to make the resection of this hypothalamic hamartoma. There are also specific protocols that can procure safety for children, for example, for this the infection of shunt prevention. And I'm very, very proud to cite this article of my friend Kalangu that is very recent, and he achieved with a very simple protocol a rate of 1.9% of infections, and which is a very, very good percentage of post-infections of infections in shunts. And you can see all these protocols that all are also available with the first have been published by Professor Schultz in 1992. I think that the healthcare system have also a role, since if you have a private system, you can have in some hospitals all the tools, but people cannot accede to this kind of hospitals. And if you are in a free system, you can have the same management for everybody, but maybe sometimes all the tools maybe are not present. For the environment, sometimes environment can guide your management. And for example, this very beautiful paper of this year of the team of the Cure Hospital in Uganda, where they have proved that ETV is safer than shunts in young babies in sub-Saharan Africa, because we know that shunt malfunction is very, very life-threatening in these countries. Also for craniopharyngioma, we know that the trend now is to perform a subtotal resection with radiotherapy, but they are still now pro of the radical resection. But even the pro of the radical resection will say that if you don't have the family structure and socioeconomic conditions, you will not achieve good results and then safety of your patients. So the future, of course, maybe will come from artificial intelligence. And when we look at the nice paper of my friend Isabel with all the collection of data in neuro-oncology, we can imagine a collection of data for parameters of safety in the future to give the best management. Augmented reality also maybe will give us more and more safety for our patients. And with this project that will finish in, at the end of the month, maybe we will have more answers in this field. So I think that, of course, everybody knows that as physicians, the child safety that we are managing must be our primary concern. And I think that before treating a patient is to we should know what the parents are expecting in these children. And what we have to do, particularly in low and in medium income countries, is to propose the best treatment regarding all what I have said, the patient, the disease, my tools, and the environment. And also we have to be humble faced to some pathologies such as craniopharyngioma, and our ego mustn't may be very important, and we should know how we can refer the patient to teams that are more specialized than yours. So I want to say thank you to my team. Here are my small team of the pediatric division with the anesthesiologist Sabeha Gidush, which is doing a very, very wonderful job, and the surgeons Nabila, Wasila, and Nazim. And I hope that in the future we will improve more and more the safety of our patients in our department. Thank you so much.
Thank you, Saad, for your presentation and for being committed to the time. We don't have much time because we have to finish this session at 4:30. So we just have 20 minutes remaining, and I hope we have some time for discussion at the end of this webinar. Now I invite Professor Francisco Meri, Professor of Neurosurgery at University Católica in Chile and General Secretary of Neurosurgical Society of Chile, is going to speak about aneurysm surgery safety peers.
So greetings from Santiago, Chile. It's my pleasure to be with you today. Thank you very much for the invitation. Now we're going to talk about aneurysm surgery and some safety pearls. Aneurysm surgery is a highly technically demanding field. It requires proficiency in several skills, such as the correct use of the microscope, effective exercise of microsurgical techniques, adequate transformation of the angiographic information to the real surgical field, and a proficient clip application. It's a fascinating surgery, but if something even small goes wrong, we could have a catastrophic result. So in the next few minutes, we will discuss some safety tips that could be useful not only for residents and young neurosurgeons, but maybe for more experienced ones as well. We're going to discuss some topics. First, the importance of training, patient selection, proper preoperative planning, intraoperative technique, and then I will focus on intraoperative evaluation methods and a little bit of postoperative care. Regarding the importance of training, aneurysm clipping is challenged by many factors. While the number of aneurysms undergoing microsurgery has decreased, the complexity of the cases has increased. So this is mainly because of growth and development of endovascular techniques. So it has become more difficult for the faculty to effectively teach residents. One thing with this is vascular neurosurgery should be considered as a subspecialty. So if you're really interested in becoming a vascular neurosurgeon, you should seek a cerebrovascular fellowship at a high volume center to get enough exposure of these cases in a short period of time. And also, it means that we need to adapt and look for other ways of training. One way of training is the simulation. And that offers an alternative way for residents to improve their skills in a safe and stress-free environment. This can be achieved by using cadavers, virtual reality, or 3D printing. This model was developed and evaluated in our department. This has two pieces. You can see in the left, in the picture, there's a yellow one, there's a frontal orbital piece, and in gray you have the skull base. And the midline, you can identify the anterior communicating and the vascular tip aneurysms, which can be clipped by the residents. And the main strengths of this model are the highlighted realism, the sustainability, and the low cost involved in the implementation. Isabel, who's with us here, was also involved in this work. This is the model being used in a WFNS bootcamp in a recent meeting in Chile. And you can see on the right the simulation setup after the craniotomy was performed. On the left, we can see the faculty and residents involved in the training. On the bottom left, you can see the residents clipping an ACOM aneurysm under the microscope. Here we can see the high global scores in the evaluation. The happiness reflected in many highly enthusiastic residents and faculties involved in and really engaged in this training activity. When you approach patient selection, please walk before you run. It's very important to start with not so difficult cases, and then when you develop more experience, you will feel more comfortable doing more complex cases. Be humble enough to seek advice and to collaborate with senior attendings, form a multidisciplinary team, and consider all treatment options, microsurgery, endovascular, conservative, and explain these options to the patient and family members and make them participants in the decision-making process. When you approach preoperative planning, please use all imaging available. In this case, we used dual volume angiogram to visualize the aneurysm and to perform virtual surgery. So here, first we place the head in surgical position, then we perform a small craniotomy. And then if you use CTA or angio as only X-ray plain films, it's going to be hard to imagine how the aneurysm would look like in surgery. But with this approach, you can visualize how it's going to be in real surgery. In the intraoperative steps, I will focus on the technique. We always should use sharp, precise dissection when splitting the sylvian fissure or dissecting the aneurysm neck. I think blunt dissection is the main cause of premature rupture of the aneurysm dome. Here we operated on carotid ophthalmic aneurysm and resecting the anterior clinoid process intradurally. So hemostasis is extremely important. It's essential to operate in a clean field, especially under a microscope. Regarding the microscope, I would advise to be one with the microscope, to master its movement, to train with a mouthpiece if available, to free your hands and allow to continuous operation. Here we're resecting the anterior clinoid process, taking a look at the ophthalmic artery and the aneurysm, and always have proximal control. In this case, we used the carotid artery at the neck. And then we perform the final clipping, which is easier if we follow these principles. It's a final look at the aneurysm and the ophthalmic artery. So why we should use intraoperative evaluation? Because inspection is not enough. Even if you're an artist in clipping, in 20 to 30% of the cases, the flow is going to be reduced after clipping. That can be directly because of clipping of a branch or a parent artery, or indirectly because of atheroma or calcification, kinkings, or thrombus formation because of long temporal clipping time. In this equation, you can see that the flow is highly influenced by the radius. So for example, in a 3 millimeter vessel, if you reduce only by 0.5 millimeter this vessel, the flow is going to be reduced by 50%. So the main purpose of the intraoperative evaluation is to maintain the integrity of the cerebral blood flow. And then you have two types of intraoperative methods: the anatomical visualization, where the angiogram is, or based on physiological parameters. You can use flow measurement, or if you don't have flow measurement, you can use Doppler or neurophysiological monitoring. This is the microvascular flow probe used to perform the flow measurement, and it uses two-way ultrasonic signal transducer that measures transit time. What is important is this is not Doppler, which reflects velocity. This tool measures actual flow in cc per minute and also gives you the direction of flow. This is important because you get quantitative data, so you can learn and make valid decisions intraoperatively. The main advantage of the intraoperative flow measurement is that it's fast and reliable. You can do as many times as you wish. Usually is before and after clipping. And in case of reduced flow, you can readjust the clips and then perform a flow measurement again. It's highly complementary to ICG video angiography. This is an example of the wide neck MCA aneurysm with two branches coming from the base. On the right, you can see the preoperative imaging of this aneurysm. This is the intraoperative view of the same aneurysm. We can perform a flow measurement of the temporal and the frontal branch before clipping. And here the temporal is 20 cc per minute and the frontal is 30 cc per minute. Then we decide with the simplest clipping approach first, in this case a slightly curved clip along the axis of the bifurcation. Some atheroma of the neck, but looked okay. But well, it's a surprise as one branch is a little flow and the other was occluded. So immediately we remove the clips, we check the flow again, and wait for a few minutes to reperfuse the brain. And then we approach with a different clipping approach, in this case, in perpendicular to the bifurcation using fenestrated clips because of the stronger closing force. Then we measure the flow again to see if everything was okay. And then we add some more clips to finish the clipping, and the final flow measurement revealed that the flows return to baseline. So, and some fiber glue at the end for the small remnant to keep the vessel patency. So every time I see this in the OR, I say, wow, this can really prevent problems. This is one of the main studies showing the usefulness of intraoperative flow measurement. It also illustrates that the flow probe provides real-time immediate feedback about the vessel patency, and also how when the flow is reduced after clipping, how it returns to baseline. So if you don't do this, even up to 25% of the cases could have a stroke. Other intraoperative tool is the ICGV angiography that allows angiography through the microscope that confirms patency in small arteries, especially perforators, and assesses residual aneurysm sac post-clipping. It's complementary also to flow measurement. Remember the preoperative planning that we performed the virtual surgery before? This is the intraoperative view of the same aneurysm. Please realize how similar are those images. So we measure flow before, then we perform a standard clipping. We measure flow again, which remain unchanged, and we puncture the aneurysm, then bust it, and placed a second safety clip. So once we are satisfied with the clipping, we can perform the ICGV angiography through the microscope to check for the aneurysm sac filling that's not filling anymore in the aneurysm sac. And also we check the patency of the distal branches. So as you can see, this is highly complementary to flow measurements. Intraoperative flow measurement also can help us to perform and decide if you are doing an STA-MCA bypass. I think every vascular neurosurgeon should be proficient in this technique, either for rescue in cases where a parent artery or a branch is occluded, or as part of a planned treatment in very difficult cases. So here you can see on the left that we are measuring the gut flow. That means the capacity of flow that this vessel can give you after you're cutting free the STA from the scalp. And this the amount of flow that is this like a donor vessel. And then you can compare it with the deficit of flow when you measure the flow in branches that are going to be occluded under temporary clipping. And if the cut flow is enough, you can perform an STA-MCA bypass. If not enough, you can perform a more complicated procedure with another conduit. And in the middle, you can see measuring the final bypass flow after the anastomosis is performed. This is an example of how the intraoperative tools help us treat this giant fusiform, partially thrombosed MCA aneurysm with an STA on the right, STA MCA bypass, filling nicely the MCA territory, and proximally distal trapping of the aneurysm with a good angiographic and clinical result. And you can follow this patient non-invasively forever using NOVA, which is software of quantitative MRI that measures flow in the perioperative period. So with this, there is no need for angiogram anymore unless there are decreasing flow over time. And some words about postoperative care. We must pay attention to details in order to avoid potential complications. I will advise to reassure always the patient and family and educate your patient well. quit smoking, for example, is a powerful tool for to reduce the rupture risk in conservative management about 3 or 4 times. Finally, if you follow your patients well, you're going to improve your practice, be a better doctor and a better surgeon. In summary, aneurysm surgery is exciting, but also very challenging. And appropriate training is extremely important, and probably 3D simulation would play a vital role in the future. Intraoperative evaluation improves the outcome of our patients. I learned this way of working in Chicago with my mentor, Dr. Fadi Charbel. I'm very grateful to him and his team to allow me to train there many years ago. And we've tried to replicate the same model in Chile. It's a good thing your teams give you freedom to innovate and explore new things, which was my case. And this is the team we've formed and creating a great place to work. To conclude, we have applied to host the next Latin American meeting. So I hope to see you all soon in Chile. This is my email address in case you would like to contact me, and thank you very much for your attention.
Thank you very much, Franco, for this presentation. Now I have some questions in the panel. The first question is to Professor Servadier. Is there a clear-cut age limit for surgery in TBI? What about other factors like Glasgow Coma Scale score or brainstem reflexes?
Well, I have already touched this point. First of all, the age, we don't have an age, a clear-cut age limit. What we know for the randomized studies and the series published in decompression, over 75 years, the possibility of good outcomes are possibly non-existing. So there is a clear-cut limit for decompression. For general trauma surgery, the only limit is a combination of different factors. Whenever you have a real Glasgow Coma score of 3, meaning no reaction to pain and no reaction to pupillary light, then there is no indication. We don't have any other indication for stopping surgery.
Thank you, Franco. The next question to Isabel. What is your advice in low resource settings? What to do to ensure effective neuronavigation?
So I think that the cheapest tool is the ultrasound. And the ultrasound cannot be used prior to making the craniotomy because it doesn't go through the bone. But once you have the craniotomy made, then you can use it before you open the dura, and you can navigate and see what the lesion that you're taking out looks like. And then you can compare those images to after the resection. Ultimately, I think that the best tool for neuronavigation is neuroanatomy. So I think that if you spend time understanding those images pre-operatively, it's time well spent because it will be very, very helpful at the time of the surgery.
Thank you, Isabel. I have another question. I don't know if it's for Yusuf or for Franco. The question is, if the World Federation Neurosurgical Society Spine Committee has specific surgical safety checklist for spinal operations. Yusuf, do you have any idea about this?
Yes, I think that there are many associations as North American Society of the North American Spine Society had a checklist derived from the universal protocol. But the difficulties is to adapt this checklist to each institution. So some association or society make their list, but it should be adapted to each hospital or each institution.
Okay, the last question.
That's why there isn't a clear checklist.
Okay, thanks, Yusuf. Our last question is for Miguel. Is there any particular technique to do a correct muscle packing?
Sorry. Basically, we take advantage of the biological properties of autologous tissue. But if I may add something, the only trick would be just smash the muscle just to release trypsin that apparently increase adhesion and increase the possibility for healing and just produce a more, let's say, healing process. But this is the only issue. Apart from that, you have to use the muscle as packing, and according to the location of the involved vessel, we are talking about the sphenoidal sinus, where more commonly we have the bleeding during endoscopic skull-base surgery, just putting the muscle and just putting a fluid and compressing this packing.
Thank you very much, Miguel. I think now I have to thank everybody. I would like to thank all our distinguished speakers for contributing to this webinar. It was really a great symposium, and I will give the talk to Professor Franco Servadier to close the webinar.
Before
Yeah.
closing the webinar, I just wanted to thank all the speakers who took the hassle, and they took very much from their time to enrich our knowledge and to refresh our knowledge as well. Thank you, all of you. Thank you very much indeed.
Thank you, Professor Osama Al-Ghanam, very much. Thank you.
Thank you. Also, I think I made it very, very quick. I think the webinar was very interesting. I think as far as we have seen from the chat, there were a lot of questions and many positive comments. This is a good experience. As I told you before, we are extending the audience towards countries with limited resources. There was a question at the end, what can we do for helping the low-income resources to improve neurosurgery? This is an example. We can do much more. We are trying to do with the help of the foundation, education, training, but keeping in touch among each other, listening to the best advanced word and see how we can apply in our resources. That's the most important. So thank you all for being in this seminar. Thanks for all the teachers and for all the attendees. And thank you, Nasser and Isabel, for organizing this session. Thank you.
Thank you very much.
Thank you very much.
Dr. Nasser.